Professor Frank, thank you so much for coming on today. I mean, I think the word expert gets thrown around a lot, but I think you generally are an expert in your field. So I just want to start on that and to talk about who you are and what you specialize in.
Perfect. Thank you, Asif. Thank you for having me. It's great to be here. So I guess my journey started with training a while ago. I actually trained in India in a place called Bangalore, came over to the UK in 2000, did my specialist sort of training in Merseyside in diabetes endocrinology, and became a consultant back in 2009. Ever since then, been looking after people with diabetes, both type 1, type 2, and endocrinology across the width of diagnoses that come with that. Over the years, built a team of clinical researchers. We have a clinical trials unit where I work up in the Northwest in a place called the Countess of Chester Hospital. And we've been doing clinical trials in diabetes, endocrinology, for a while now. And over the years, my interest has kind of been in obesity medicine. We've been trialing a number of the current obesity medications, the GLP-1, GIP agonist therapies. I mean, we started doing this back in 2007 and 8 when the original GLP-1s came out, injections twice a day and stuff like that. So over the years, developed that interest in obesity and then went on to develop a clinical service in the private sector as well as in the NHS, looking after people with obesity. In the private sector, over time, it's grown to develop what we call the Dr. Frank's Weight Loss Clinic. We've looked after over 10,000 patients now using medicines like Wegovy and Mounjaro, which are really the buzzword medications now that people talk about with, in the realms of obesity medicine. Still keep my active sort of pure endocrinology and diabetes activities up, both in the NHS as well as in the private sector. So look after the breadth from thyroid to men's health with, testosterone, as well as women's health and the menopause, PCOS. So the whole spectrum of anything to do with hormones. I'd like to think I'm able to look after people and give them a decent level of care. So that's the aim.
No, great. Yeah, I mean, I actually came across you because I saw Dr. Frank and I thought, okay, look, is this actually a doctor or is it just, and I thought, okay, look, this guy must be an expert if he's putting his name on what people consider to be the hot topic right now. But interestingly is that you still do the NHS general medicine side of things, which I think, many people in your position may well have given up because I guess there's no need, I guess some people might think there's no need, right? Because you must be so busy with the weight loss side of stuff. So, but yeah, that's why I was interested in getting you on because I think you're grounding in the whole kind of breadth of medicine, which you can get de-skilled in quite quickly. So look, I think, weight loss, right? Especially, and there's lots of things, I mean, there's so many things I want to talk about with you, but I think the key one is weight loss and the medications. But I think one thing as a GP, I think we see is what I see is when patients come in, they've reached a certain weight, and no matter what they try, so they try dieting, they try exercising, the weight won't come off. And I think as GP, sometimes we're a bit guilty of thinking, oh, yeah, they're not really trying, but they genuinely are trying. So is there like a switch or is there something that happens when people reach a certain weight or put in a certain amount of weight where they just can't lose weight? Is that a thing?
So yeah, absolutely. So it's interesting. Obviously we know that obesity, weight gain is significantly contributed to by genetics, right? But the point is, in addition to genetics, you also have environmental things that happen to you. So there's, where you're brought up, the diet you're brought up on. There's so much mental health overlay in terms of what contributes to obesity as well. Going through traumatic events in childhood, youth can also contribute to that, emotional eating. But eventually it gets to a point where once you've put on so much weight that you go beyond beyond the point of no return in a say, where essentially what you're dealing with is your biology changes to the point where your body becomes so accustomed to having a store of energy. I mean, I the way I tend to put it to patients is, think of it as a savings account. So our bodies are designed genetically to save for a rainy day, for when famine comes, and some sort of ethnicities are even more predisposed to that. So, being from a South Asian background myself, they call it the thrifty genotype. And the thrifty genotype basically means you save for a rainy day. And the plan was that the body would store abdominal fat so that it was a source of energy in case famine ever came, that you could actually delve into that store so that you'd survive for longer. Problem is, famines never come. On the contrary, we've now got, fast food, super, processed foods and calorie counts that we can't keep track of because everything has got something in it. And as you get to the point where all those calories are stored up, your body begins to enjoy having that sense of security that I've got all this energy stored up. And after that, you get to a point where your hormones go completely out of sync, where you're unable to reverse that energy sort of surplus by depriving yourself of calories and energy, because the body then doesn't have the mechanisms to say, actually, I'm happy with less now. And that's where these medications and the hormones that now we use to try and help people with obesity have come from. Essentially, they're the hormones that are our off switches that go to your satiety centers in your brain and say, guess what? You don't need to eat that much. You've already got enough. You don't want to be eating more and more to satisfy yourself, but you don't have those switches. So once you put on a load of weight, you actually need more calories, more food to be able to satisfy yourself.
Oh, I see. And turn off that switch you're talking about.
And turn off that switch.
I think we should just go back to something. So maybe talk a bit about what causes hunger and that your whole kind of hormone. Because I think what you're talking about is almost like a hormone switch, right?
It is.
But if we can briefly just go over how that works, essentially, before if somebody gets obese, and why that switch is sometimes almost, gone further up in terms of how many calories you need, etc.
For sure. So in basic terms, you have hormones that are made from your fat cells and from your stomach or gut, as well as from your brain, right? So you've got hormones. So ghrelin is probably the best one to talk about. So ghrelin is a hormone that makes you feel hungry. It comes from the stomach and stimulates appetite. So it makes you hungrier. Then you've got hormones like leptin, adiponectin. So these are hormones that downregulate appetite as well. But none of these, these have all been explored over the years to try and find solutions using these medications to try and treat obesity. Unfortunately, they're so complex molecules, they're not easy to make into medical therapy. So as time's evolved, people narrowed it down to the two hormones, which are GLP-1 and GIP. And GLP-1 was the first one that we were able to identify and turn into a real potential medical therapy. So what does GLP-1 really do? So the normal physiology is that when you eat food, so food goes in through your mouth, down into your stomach and your gut. Your gut senses the food has arrived, okay? So once the food's arrived, your gut produces GLP-1, and GLP-1 then travels from the gut to do four main things. So one, it actually goes to the pancreas and says, look, food's arrived, make the right amount of insulin to deal with the glucose load that's arrived, okay? The second thing it does is goes to the liver, and it says to the liver, you know what, there's food here. I don't want any of the glucose that's stored in the liver as glycogen to come out to play. I want it to stay in there. So it reduces the release of glucose from the liver. So these two mechanisms are key for these hormones being treatment agents for type 2 diabetes, because these two things contribute to type 2 diabetes, right? Lack of appropriate insulin production and a lot of glucagon-based release of glycogen into the bloodstream. But the main thing that the hormones do in relation to people who don't have diabetes, as well as in people who have diabetes, is that they go to kind of making people feel full in two ways. One, it slows your stomach down physically. So it slows gastric emptying, as we call it. Okay. So you physically can't put as much food into you, because if you try, you'll feel very uncomfortable, very full, feel more nauseous, and even be sick potentially. But the main thing it does is it travels up to your hypothalamus or your satiety centers in your brain and says, guess what? You can stop now. You've had enough and you don't need to eat anymore. And so in those four ways, what it allows you to do in diabetes is restrict your calorie intake, but also reduce your glucose levels. So it treats type 2 diabetes really, really well, but at the same time also helps people who don't yet have diabetes control their obesity and their weight gain by helping them live on much, much less calories.
I see. And now, so that makes a great explanation. I've never heard anyone explain it so quickly in a couple of minutes. But so with people that get obese to a certain level, what happens to the hormones then? Do we know if the GLP and GIP reduce in there?
Yeah. So essentially it's downregulated. So essentially you have less GLP-1, less GIP production once you start to become overweight and obese. And that's called something called the incretin effect. So there's an experiment that they talk about classically, right? So the experiment is that if you give someone with type 2 diabetes glucose intravenously and measure the amount of insulin that they produce in response to that, it's less than the amount of insulin they release when you give them the same amount of glucose required to achieve the same amount of glucose level in their blood orally.
Oh, wow.
Okay? And that's because these hormones are the key messengers between the gut and the pancreas.
Oh, got it.
So unless you have these messengers working correctly with the sufficient amounts, you don't get the right amount of insulin secretion. So they're called incretin hormones. And it's that difference between the gut being a key part, the gut and the cross messaging between the gut and the pancreas being a key part of how glucose metabolism occurs.
And how hard is it to reverse that? You know you said it's very hard once you reach almost like a cliff edge, right?
Yeah.
But how hard is that? Is it almost impossible to reverse that?
So that's a great question, right? I wish there was a straightforward answer to that. There isn't. It's very individual and very dependent. So, for example, if you take someone who's got a high BMI and has gone to pre-diabetes, let's say, right? And they're on the verge of developing type 2 diabetes. We know that there are programs where you could do an 800 kilocalorie restriction for 3 months, you know, and reverse that trend. So depending on how aggressive you can be with the intervention, you will and can, in some instances, be able to reverse that and take yourself back. But you're always going to be constantly trying to battle a little bit. What we know is that, you know, the National Diabetes Prevention Program is a great example. It's based on the theory and based on a clinical trial that was done up in Scotland and Newcastle, where they gave people with type 2 diabetes in the early stages, first 5 to 6 years of type 2 diabetes, 800 kilocalorie restriction for a 3-month period, right? And, you know, 800 calories is very difficult to do. And they gave people the option, should we do this with food that you cook and put together, or do you want to just do soups and shakes? And almost everybody said, I'll do soups and shakes.
It's easier, right?
It's easier. You don't have to think about it. You do it. And that's the basis for the NDPP, as we call it, right? And what you do is by doing that 800 calorie restriction, you are literally reducing calories going in. You lose weight as a result, you reduce your insulin resistance, and you start to bring your glycemic control and, you know, back down to where it should be. And in doing so, you start to manage your hormone levels in a way that you're able to live on lesser amounts. But once you get to the 3-month period, what we do is we introduce little bits of calorie increment, right? And the people who lost the most weight were able to keep their diabetes in remission for the longest period of times. And the more weight you lose, the more likely you'll stay in remission 12 months down the line, 18 months down the line. So yes, it can be done. It's very difficult to do. Almost invariably with most things that we do that are dietary based or lifestyle based, there's always going to be a little bit of weight regain, which is why we talk about yo-yo dieting. Right?
Yeah.
People always ask me, well, what's a good diet? And I say, well, a good diet is a diet that works for you, that will allow you to sustain your weight loss and keep you healthy. And that could be intermittent fasting. It could be a 2-5. It could be the carnivore diet. It could be keto. It could be anything. It could be low carb. The main thing is to work out what you can do that is sustainable and achievable, whereas otherwise it's just a fad. And if it's a fad and you can't stick with it, which is difficult to do for a lot of people, all you do is you lose the weight and then you regain. Now, that's not necessarily a bad thing always, right? Because actually for a period of time when you do lose weight, you do improve your glycemic parameters, you do improve your metabolism. And that has a legacy effect to some extent where even that period of time when things are better, you've given yourself a break from having poor metabolism in your system, which then means theoretically your cardiovascular risk for the future is better. So just because you failed doesn't mean it's a bad thing to try again and try again. The challenge is you get so frustrated by the time you've tried for the nth time, and then you're looking for, well, what's my permanent solution to this? Because otherwise it's just, you know, I've given up now and I don't know what else to do.
Yeah, and interesting, at that point, a lot of people kind of put it down to genetics. And interestingly, I was looking at some papers. Now, I can't remember the name of the exact gene, but I think, you know, the Pacific Islanders have this specific gene where I think it's got something to do with obviously with famine and, you know, going back in time where they just put on weight and fat and store it.
Yep.
And a lot of people say, oh, I've got this gene, right? I've not been tested, but I must have this gene. How common is the so-called fat gene? And is it a thing?
Yeah, so it is a thing.
Yeah.
And it goes back to the whole thrifty genotype that I talked about. And like you said, you know, Pacific Islanders are a good example of that. But essentially in the general population, you tend to find that South Asian populations tend to have a higher risk of that. Caucasian, not so much. But again, there's so much influence of environment on genetics. It's very difficult to dissociate the two. There are obviously certain monogenic conditions, right, where actually you have a single gene defect like leptin defects, etc., where you can only treat, people in the young sort of, childhood development stages where they need specific therapies. But generally it's polygenic, a lot of influence from environment. And the challenges are a balance between what genes are and the environment is, and your biology becomes as a result of the combination of the two.
Oh, interesting. Yeah. Because I remember seeing, so I think that one of the place in the world with the highest obesity rates is a South Pacific island somewhere where I think something like 80%, something crazy is high. But and I think they did isolate a gene in them specifically. But how important is muscle mass in weight loss? Because I think, as you mentioned, the calorie restriction and diet or fad diets are quite hard to do, and you should always try to implement lifestyle changes. And one of those, a lot of people sometimes push towards cardiovascular exercise because they can burn, 500 calories an hour by running. But what is the importance of muscle? And and obviously I think people are realizing if you've got muscle, maybe it does increase your calorie expenditure throughout the day. How is that marginal, or how does that actually have an impact long term for weight loss? So if you've got, if you increase your amount of muscle mass, that will sustain weight loss for many years.
Yeah, so there's two bits to that, right? So one is when you do aerobic exercise, what you're doing is you're increasing your calorie expenditure.
Yeah.
Okay. And as a result, if you get to a calorie deficit sufficiently, you'll lose weight. The problem is when you stop doing aerobic exercise, you still have a basal metabolic rate that you've got to maintain. Now, the problem with the basal metabolic rate is that is dependent very much on the amount of muscle mass you have. So if you want to have a higher basal metabolic rate, you're better off with a little bit of extra muscle on you. Because if you do a lot of aerobic stuff and you lose muscle mass as well as fat, in between your exercise routine, you're not expending as much energy. The other thing I also have to say to a lot of my patients is, they try. So there's two bits to this. One is, it depends on where you are in your journey. If you're at the point where you are already living with obesity, then what you've got to realize is that if you're already a fairly active person, you have not a desk-bound job, you walk around, you do stuff day to day, but you're not losing weight, it's unlikely that you're going to go past a certain level of calorie burn with exercise in a day. So there are studies which show you that, you'll max out at about 2,000 calories a day, maybe a little over 2,000 in terms of calorie burn if you exercise in a day, if you're already kind of active, right? If you really want to exercise away, you're going to have to do a hell of a lot of running. You're probably going to have to do a 5 or 10K every day to be able to keep that level of calorie burn up. So it almost always boils down to calorie restriction when you want to try and lose weight, because that's the only real surefire way for you to move into a calorie deficit.
I see.
The other bit is the moment you do high intensity cardio, you kind of suck up all the glucose that's floating around in your blood. So what does that do? Well, it makes you hungry. And then you go and grab something because you feel like you're going to pass out because your blood sugar is starting to drop. And what that does then is it just replenishes the sugar you've just tried to burn away. You don't actually give yourself time to get to your fat stores. So one of the things I have to actually tell a lot of my patients who do a lot of high intensity stuff is they've got to detrain. Because actually, if they want to lose weight, they've got to do almost moderate intensity, longer duration, so that they actually allow themselves to get to the fat cells, to get where they need to get, to their stores. And at the same time, I recommend sort of resistance exercise to build up muscle mass so that they maintain their basal metabolic rate at a slightly higher level. When you think about medical treatment, so, if you treat people with medications like Wegovy or Mounjaro, we know that not only do you lose fat, but you also lose a little bit of protein. And that's why it's important that when you're on medical treatments for weight loss, you're also managing diet in a way that is slightly lower carb, slightly higher protein. And we always recommend a degree of resistance training or light weights, just to keep going, because that really helps to sustain the weight loss on a longer term. Because if you just lose a lot of weight in terms of fat and muscle, your basal metabolic rate shuts down or goes down. It slows down. So you're like, well, I'm taking this stuff, I'm eating less, but I ain't losing as much weight. And that's because you can only go so far in terms of calorie restriction and burn. After that, you've got to let your basal metabolic rate sort of take over to keep that ticking over in a way.
No, that's really interesting. And going into diets, I think there's lots around about high protein diet. Have, if you want to build muscle, have almost 1 gram per pound of body weight. So what are your thoughts on specifically a high protein diet. So almost like not carnivore, but I mean like, not ketogenic either. So high protein, that kind of number. Is that beneficial? Have you seen it, even for people who don't want to build muscle and just lose weight? Is the number you should work towards?
Yeah, absolutely. I think there's two ways to look at this, right? You got to always talk about diets in people at the stage of their weight. So if they're obese or living with obesity or overweight already, then yes. In my experience, I mean, back in the day, it was always low fat, right?
Yeah.
But we've realized that low fat was the wrong message really for us, because actually low fat hasn't stopped us developing the obesity and the type 2 diabetes pandemic or epidemic that we're dealing with, right? So essentially what we've realized is it's carbs that tend to be the issue. And so what's the easiest way to go low calorie? Well, the easiest way to go low calorie is to go low carb. What's the easiest way to supplement your carbs so that you don't feel hungry? Well, you go high protein, high fiber. The main thing is if you're not living with overweight or obesity, but you're, kind of in a healthy-ish weight and you're just trying to maintain that, then it's all about balance. So it's about carbs, proteins, fibers, fats. You got to have the mix. But once you're dealing with being overweight or obese, you've got to find a way to bring that back. So the only way to bring that back is to bring your calorie content down. And you have to therefore work on low calorie density foods. And the highest calorie densities tend to be carbs and fats. So essentially, you've got to cut down on carbs and fats, replace with protein and fiber, and therefore protein is definitely a yes.
Yeah.
And especially when you, as an endocrinologist looking after people with type 2 diabetes, I mean, I've spent years saying to people, the reason I treat type 2 diabetes is because I want to prevent the complications of type 2 diabetes. Yeah. I don't want you to go blind. I don't want you to have feet problems. I don't want you to have heart attack, strokes, all that kind of stuff. But actually now I say, well, type 2 diabetes is a complication of obesity. So I don't want to treat type 2 diabetes complications. I want to treat the complications of obesity, which is type 2 diabetes. So we're moving one step up the pathway so that we stop having people to get to a diagnosis of type 2 diabetes. And that then means that you're not having to deal with all the other consequences that you get once you've been diagnosed with type 2 diabetes.
That's super interesting. And one thing I want to touch on, you mentioned importantly, a lot of people talk about on diet, talk about fats, carbs, protein, but fiber. I'm glad you mentioned that. Of course, as you would, because what if you can just discuss the importance of fiber and the role of fiber, also in glucose management, because I think a lot of people don't realize it makes you feel full for longer, but also it has way more implications than just that.
Absolutely. I mean, fiber is so crucial, right? So, in my world, in terms of trying to help people lose weight, the satiety thing is a big thing. But more than that, it's about gut health, right? We know that you need decent forms of fiber, amounts of fiber to ensure that your bowel transit is good. You need to make sure your bowel health is good. I mean, there's so much research now around, gut health and about the microbiome and how that influences all these kind of things.
Yeah.
And fiber is a crucial part of that. In the Western world, because of historical diets, diverticular disease is such a big issue. And again, you've got to find ways before you get to that stage that we try and use diets that are rich in fiber, and that could be plant-based, in terms of fruits and veg. People use stuff like chia seeds and, pumpkin seeds and stuff like that. But it's finding ways that you can increase the fiber. Simple things like if you want to eat fruit, I'd rather you ate fruit than you put it into a blender and made a smoothie. Because actually you lose a shed load of the fiber when you process it, right? So, people think that it's great to have a smoothie because, I get all my vitamins and minerals and stuff, which is great. You need those. But actually, you're better off. You feel fuller and you get your fiber in if you just ate the fruit instead.
Ate it instead, yeah. I'm a fan of seeds because they're so easy, like, pumpkin, chia, hemp, all these ones. But I think going back to we'll talk onto the medications in a minute, but I was going to talk through kind of the causes and diet specifically. Intermittent fasting, is everywhere, right? Now, I've looked into it in depth and I still haven't got a clear answer. So hopefully you can help with this. But we're talking briefly off camera about, is it just the fact it works, but is it because of the fact it's very, very hard to eat a lots of calories in, say, 8 hours, of eating? Or is there something underpinning it? Like, is there a metabolic change that the fasting does that helps you lose weight?
Yeah. So the key thing that intermittent fasting does, there is a calorie thing there, obviously, because you are fasting for a period of time. But more importantly, what it does is it gives your body time to lower its insulin resistance. That's the key. So we know that fasting lowers insulin resistance. And when you lower insulin resistance, you change your metabolism so that for the period after that, you are metabolically more efficient. So instead of storing, you are more likely to burn your calories because your insulin resistance is down. So that's the kind of metabolic reason for why intermittent fasting works so much better in people, is because you literally allow your body to have time in a less insulin resistant state. The more insulin resistant you are, the moment calories go in, you become insulin resistant.
Yeah.
Right? So people think that insulin resistance is just by virtue of you already having existing adipose tissue. But actually it's not. It's affected by so many different things, hormones such as even just estrogen and progesterone. So, women who go through the menopause become more insulin resistant. And so in the same way, even glucose fluctuation, the higher your glucose levels, the more insulin resistant you get. And you're caught in a vicious cycle because you're more insulin resistant, your glucose is high, your glucose makes you more insulin resistant, so it just makes your glucose go high. Vicious cycle. So the only way to break that, you can't literally in minutes or hours reduce the amount of adipocytes you have, but what you can do is bring your glucose levels down by fasting for a prolonged period of time. By doing that, you are within minutes to hours, you are down regulating your insulin receptors in a way that you become more insulin sensitive.
Interesting.
And therefore, your body then for the hours after that, your body is more insulin sensitive and therefore more metabolically efficient. In a simple term, and therefore you don't store as much in that period of time.
Interesting. Essentially, so also when you do eat, your body's almost starving the glucose, so you don't have a massive peak.
Absolutely.
That you don't want. Now with the insulin resistant stuff, like. Again, people throw that term around without really, like you just mentioned, without understanding what it is. A lot of people think, if you just have lots of sugar, eventually you'll get insulin resistance, which there is some truth to that, right?
Yep.
But if you talk just very briefly, because I know this is something you'd probably talk for hours about specifically, but what are the causes of insulin resistance? Because that's almost like a precursor to getting diabetes, right? So what are some of the things that you've seen that people do predominantly that cause them to become insulin resistant in terms of disease or lifestyle or anything like that?
Yeah, so in terms of, you got to obviously distinguish the disease bit and the lifestyle bit, right?
Yeah.
So the disease bit we know a lot about. So first of all, we know that insulin resistance is genetic because we have insulin resistance syndromes that occur, right? So we know that there's a definite genetic component there. Probably the one clinical scenario where insulin resistance plays a really big role, even before you get to type 2 diabetes, is PCOS, right?
Yep.
So women with polycystic ovary syndrome are inherently insulin resistant, whether they have slim PCOS or they have the traditional sort of overweight PCOS, right? So in the overweight PCOS, which is what most people will associate with polycystic ovary syndrome, insulin resistance is an underlying issue. That insulin resistance then has all these other impacts on male to female hormone ratios, hyperandrogenism, irregular periods, all of that kind of stuff. But what leads to that is there's genetics. The genetics then also contributed to by exactly like you said, it's diet. It's about carbs, calories, sugar, and carbs. More and more, I notice, and my patients feed back to me, is that even within carbs, it tends to be gluten-containing carbs that tend to be an issue. And that's why in PCOS, they talk about PCOS being a chronic inflammatory state as well. So, when women with PCOS go gluten-free, they tend to find that they feel less achy, they feel less uncomfortable, their gut's better. And at the same time, because they've gone gluten-free, they almost invariably go low carb and therefore lose weight, and therefore the insulin resistance gets better, and everything sort of starts to fall into place. So you've got, diet, exercise as well. So we know that if you exercise, it brings your insulin resistance down. Literally exercise.
The next big thing, I think, other than intermittent fasting that's going around is around the carnivore diet. Now, so purely just, meat, eggs, no carbs, nothing like that.
Yeah.
What are your thoughts on that? And is it helpful?
So I do get a lot of people who try different things. And I think the carnivore diet has got its upside. I guess you could liken it a little bit towards a low carb, high protein keto kind of diet, because mostly it's all protein based on meat, eggs, etc. And the thing you realize with a lot of patients with the carnivore diet is, they do report that they are losing weight, and that's usually because they're low carb, because that's what the diet lends itself to. The second bit around it is also a lot of people notice that a lot of their IBS symptoms and stuff get better as well. And some of that is, again, down to the fact that a lot of the other stuff that we eat nowadays, mostly in the carb form, tends to be very processed. And actually, the moment you start to move away from processed food, stuff that, we've gotten accustomed to in the modern world, and go back to what we were like, hunters, gatherers, that kind of thing, you're then starting to go back to a metabolic pathway where your body's going back to its kind of roots in a way. And so I think there's an upside to it. I think the benefits tend to come from the fact that it's mostly protein and fiber based. And also there isn't a lot of processing within the foods that we eat. And I think that's why people tend to find it very, very beneficial for some people. There's no sort of huge clinical trials showing that they work or anything like that. Not like intermittent fasting, for example, where, there's been trials done showing that, it does have benefits. It's been associated with cardiovascular benefits, reversal of type 2, that kind of stuff. So I think I'm all for it. Again, I go back to the simple thing that I say to my patients, which is a good diet is a diet that works for you and a diet that you can sustain. And if a carnivore diet's what you want, then that's what you'll get. Part of the challenge also is when you go carnivore is you got to look at your vitamins and stuff because you stop eating kind of greens quite a bit sometimes and things. So you got to watch your folate levels, and just look at that a little bit as well. But, there's nothing wrong with going back to basics, I think.
Yeah, it just sounds like it's more like just almost like an unprocessed diet. That seems to be the key. And I guess the big problem with that might be fiber as well, getting enough fiber. Because a lot of people just assume eggs and meat and, but fiber's key. I'd somehow getting that in their diet. Okay, so now on to weight loss medication. So obviously we've got the injectables, which are quite big at the moment, but there's also tablets which we can give, which we can prescribe kind of orally, which is things like Orlistat.
Yeah.
So maybe let's start with the basic stuff first. So with Orlistat, what's your experience with it? Does it work, and how effective is it, and what does it actually do?
Yeah, so it has never really worked in my experience, right? It was, when it came along, it was the big thing.
Yeah.
And we all started prescribing it. And actually, when you look at the data in terms of the amount of weight loss it was allowing, even in clinical trials, you looked at, at best, maybe, 5% at best weight loss.
Really? Okay.
But actually, the mechanism of action was the big thing. It was all about not absorbing fat from your gut. And if you even let a little bit of fat into your meal, your diet, unfortunately, the side effects were horrendous. Oily diarrhea was the one thing that put most people off.
Yeah.
But the one thing about it was relatively safe. Not much in the way of side effects other than the diarrhea. And it was almost like if you knew you were eating a high-fat food, you knew you were being naughty and then therefore you paid the price. But actually, more and more we've realized that it's not about fats, it's also a lot about calories and carbs. And therefore, it didn't really go very far. It's still prescribable on the NHS. It's really the only thing that's currently really prescribable on the NHS. And you can buy it over the counter as well. And so, from my point of view, it's definitely an option. It's low cost, which is a good thing. If it works for you, again, it works for you.
Yeah, because when patients come in the first line, it always, because it's the only thing we have, right? So I tend to give it a go, but from my experience, is minimal.
Absolutely.
And having fat in your diet, even a little bit, is so hard to, because everything's got a bit of fat in it, right?
Yep.
And some people are super responsive to having that fat, and it just puts them off, right? There's a really greasy, oily food, basically. So,
absolutely.
Okay, so then that that's not that effective. The next thing is now the big thing, the injections, right? So I think the best way to go through it is maybe the different types, because there may be 4 or 5 big ones that we use in the UK, maybe worldwide, but and how they kind of work and any side effects. So yeah, I'll leave it up to you how you want to start.
Yeah, so I guess officially, the first time that the injectable therapies became a weight loss treatment as opposed to a type 2 diabetes treatment was when Saxenda was launched. So Saxenda, or liraglutide, previously was called Victoza and was a once daily injection that we used for type 2 diabetes management. A lot of people don't even remember that now, because it was, years ago, and we stopped using it when the weekly injections came out. So when Saxenda came along, it was designed to allow you to treat people with a once daily GLP-1. People won't remember this because it's been masked so much by the newer weekly stuff.
Yeah.
But you in the diabetes world, you only went up to, you started on 0.6 milligrams, then you went to 1.2, then you went up to 1.8, and that was after a lot of haggling with NICE for type 2 diabetes management. But when you do weight management, Saxenda, it goes up to 3 milligrams. But even with Saxenda, you got maybe 5, maybe 10%, and then there were side effects, and it was a daily injection. It was just cumbersome for people to do. And then in January 2000, Ozempic was launched for type 2 diabetes. And in 2000, when Ozempic came around, it revolutionized type 2 diabetes management from an injectable perspective because it really made a really hard-hitting impact, right? It helped people lose weight, improved glycemic control. And then as time's gone by, Ozempic's cardiovascular benefit was proven in terms of reducing heart attacks, strokes, death, all of that kind of stuff. Then people cordoned on to the fact that Ozempic, as a weekly GLP-1, was actually really good at helping these people with type 2 diabetes lose weight at the same time. You know, if you read the SMPC or the product literature, it lists weight loss as a side effect of Ozempic, not a benefit, right?
Yeah.
But obviously we know now that actually it's not really a side effect, but it's a desired effect when you're struggling with, living with overweight or obesity. So then Ozempic became the thing and people started using it off license or off label for weight management in people who didn't have type 2 diabetes. And then as that data grew, obviously the manufacturers, Novo Nordisk, then realized that actually there's a whole different group of people that we can help by using this. And that's where Wegovy came into play. So semaglutide was tried, tested, and not just up to the 1 milligram dose that we use for type 2 diabetes using Ozempic, but all the way up to 1.7 and then 2.4 milligrams in the form of Wegovy. So now we officially have Wegovy, which is the exact same medication as Ozempic. The active ingredient is semaglutide. But in terms of treating diabetes, you use the Ozempic brand and you use that up to a dose of 1 milligram. But the Wegovy is exact same medication, branded differently so that you separate the two indications out. So it's used for the weight loss and you go up to much higher doses too.
Interesting, because a lot of people, Ozempic is by far the most popular, right? And I took a lot of digging to try and get this on, and I still wasn't sure. So you're saying is Wegovy is the same as Ozempic, but higher dose.
But higher dose.
For weight loss.
Absolutely. So exact same medication.
So why is Ozempic so much bigger then? Like, is that just a
I think it's just because, it was first to market. It was the name that everybody associated with weight loss right from the beginning.
Yeah,
it was about 4 years ahead of its time because Wegovy came in 2024, right? Whereas actually what you had was, Ozempic from 2000 onwards in the public sector, right? And so people knew the name Ozempic. And actually, it really took off when I think it was probably Elon Musk who, when he went on X and said, I use this stuff to lose weight, it just went everywhere. And then you had Oprah, and then you had Boris Johnson, and you had Jeremy Clarkson. You had everyone you could think of trying this stuff out. And actually, that's where it became a huge celebrity thing. Social media was rife with it. And whilst I, as a physician, I try and do this very much from a health perspective, we can't take away from the fact that social media and all the hype that's gone with this stuff has put it out there for people to be aware of that you have got options. That's not necessarily a bad thing, right? At the end of the day, as long as things are done right and supervised and you get the health care that you need and the assistance that you need to do it safely, I think, these things are there to help the millions of people who struggle day in and day out with their weight. So that was kind of where the Ozempic thing came from because it was around longer, and then Wegovy took over. And then obviously after Wegovy, now we have the next best thing, which is Mounjaro. So Mounjaro is the latest kid on the block. And Mounjaro is also a weekly injection. Its active ingredients called tirzepatide. What's unique about it is it's the first in its class of a dual receptor agonist. So everything before Mounjaro was a GLP-1 receptor agonist, okay? And GLP-1 is just one of those hormones that we talked about earlier. We talked about earlier.
Levels,
It reaches levels, right? The satiety stuff. But GIP is the second one. And what's interesting about the tirzepatide molecule is that they modified it in a way that it triggers or stimulates both GLP and GIP simultaneously. And that dual action just makes it more potent than even the Wegovy. So you see a greater degree of weight loss as a result of the combination of those two receptors being targeted.
Interesting. So, I mean, this is probably a very naive way of looking at it, but it sounds like the pecking order almost is number 3 would be Saxenda, then actually maybe probably be Saxenda, Ozempic, Mounjaro, Wegovy.
No. So if you were going to look at efficacy of weight loss, as it stands at this point in time, it's Mounjaro's top of the rung, Wegovy's second. We don't really talk about Ozempic because we shouldn't, because that's for diabetes on the NHS, and we don't try and use that brand. Wegovy's the same medication. So it's Mounjaro top of the list, Wegovy second, Saxenda still there, but actually nobody really uses it, right? Why would you inject yourself every day and only get 5% weight loss when you can inject yourself once a week and get 20 to 25% weight loss?
Wow, that drastic.
That drastic, right?
Yeah.
I guess the other thing that sets Wegovy aside, though, is Wegovy, because it's been around for longer and semaglutide has been tested for longer, it has got the backing of the SELECT trial. So the SELECT trial was a trial that came out about last 18 months or so. And essentially, it showed that whether you have type 2 diabetes or not, if you are overweight or obese and you've had a previous MI, stroke, TIA, any form of cardiovascular thing, heart attack, stroke, mini stroke, whatever it might have been, if you are treated with Wegovy or semaglutide, you will reduce your risk of a further event, another heart attack, another stroke, possibly death, by 20%.
Wow.
Okay? So whilst it may not be the strongest at weight loss, the data suggests that it has this really great cardioprotective effect. And so if you've got someone who's already had something happen to them, like a heart attack or a stroke or a mini stroke, then I would probably choose Wegovy first over Mounjaro. But if you're younger and your main aim is, I need to lose weight, then Mounjaro is probably your go-to medication. The thing about Mounjaro and its cardiovascular outcome data is that the trial's ongoing. It'll hopefully be around in 2026, I think, is when it'll report. And when it comes out, then we'll know whether it does the same cardiovascular benefit that Wegovy does. But as of this time, the evidence base for cardiovascular benefit sits with Wegovy. So you have to tailor the treatment based on who you're looking after. So it's not as simple as saying you'll just use the strongest one.
Yeah.
But then there's also the bit around people tolerating one or the other. So in my practice and in our weight loss clinic, we give people the option. So some people will start on one and say, actually, this isn't really working for me, and then change to the other one, or the vice versa. And actually, that is something that's really important. It's about making sure that patients get all the options, and then you guide them through those options and support them step by step. So there isn't a clear outright winner when it comes to these things.
It's really interesting because before, obviously speaking to you, looking into it, when I knew you were coming on, it was always kind of Ozempic, right? I was kind of just what's out there, but it seems like that's not really even considered now. I wouldn't even consider it now. I'm speaking to you, we gave you Mounjaro, right? But now you mentioned tolerance. What are some of the side effects of, if any, of these medications, and what are the things that people might get that makes them come off it? Yeah.
So in terms of side effects, right? So if you do things right and you're counseled well, you can avoid a lot of the side effects. But the side effects that we tend, if I was sitting with a patient, my usual kind of, pardon me.
Okay.
So if I was sitting with a patient, my usual kind of counseling session would go something like this. Look, this is how it's going to start. You're going to start on a low dose, and we're going to build up the dose gradually. The reason we start on a low dose is because we want you to have a peaceful journey without side effects so that you enjoy your weight loss journey. The commonest side effects that you can get are nausea. Okay, and the reason you get nausea is because one of the mechanisms, as I said before, is it slows the stomach emptying. So if you think about it, the moment you take the medication, your stomach slows down. If you eat the same amount of food that you would normally plate up for yourself, there isn't anywhere for that food to go. So you'll start to feel very uncomfortable, more nauseous, and you're potentially going to be sick. So what because the food's still stuck there, there's nowhere for it to go. So what I say to people is, in the first few days when you start the medication, what you've got to do for me is you've got to make a conscious effort to reduce the portion size. After about day 2 or 3, or sometimes even on day 1 for some people, the medication kicks in and they don't have to make the effort anymore. They just automatically eat half the portion size.
It
just happens. And it's a very interesting sensation for a lot of people. They're like, whoa, how am I saying no to that? And they often talk about the noise dying down in their head, the constant battle about what they're trying to say to themselves to say, don't eat anymore, stop there.
Yeah.
That disappears for a lot of people.
Interesting.
So nausea is kind of the commonest thing, and I tell them to manage it that way. The other thing you find is in the first 2 to 3 days, some people get a bit of diarrhea. It's mild and it disappears. Some people can go the complete opposite and be constipated. And if they get constipated, we have to manage that. And the reason for constipation often is, it slows the gut down a little bit. But more than that, when you're on these things, you reduce your portion size so much that you don't actually get enough fiber going into you. So we often have to tell people, look, I need you to increase your fiber intake. And also the other thing you do is when you control your appetite so well, sometimes people's thirst also gets controlled. So we almost have to make people drink consciously 2 or 3 liters a day because you need that fluid and you need enough fiber, enough volume of food in any form to be able to get your bowels to go regularly. So those are the commonest things that people feel. We also warn people about, abdominal pain from heartburn, gastritis, because, your stomach slows down, the acid sits around for longer. Occasionally people, if they eat a little bit too much carb, they get these eggy burps and stuff. But again, it's about saying go low carb, avoid gluten if you can when you're starting off. When you lose weight, the other thing you find is that effective weight loss results in gallstone formation. So we do warn people to look out for any sort of abdominal pain in the right upper area of the abdomen. And if they do get that, they need to just get checked out. There is a risk of pancreatitis, which is listed in the medical product characteristics. I have never really seen one. It tends to be because you get gallstones and then the gallstones cause pancreatitis, right? And essentially, it's something we warn people about. They need to stop. They need to get checked out. But most people, if you counsel them right, will sail through the journey. And it's such a positive journey for them because the weight loss and that control, that feeling of being able to say no has been something that they've missed for so long that they are literally motivated to keep going. Sometimes, because it's what it is, you know. So side effects can be managed. They do happen, like with anything we give people. But it's about making sure that you look after them and you counsel them because actually, once you get past it, the side effects tend to settle as you settle down on a higher, more stable dose.
Now, with one of the things that I think I've seen people talk about is change in taste. So they may have liked or disliked foods they once liked. And sometimes a bit of a concern for people. Is that a real thing? Is that a phenomenon that happens? Or is that just,
absolutely. So people will say to you that actually, I used to love eating bread or chocolate. And now I don't even look at it. And it's interesting, what it makes you realize is that a lot of the decisions we make in our life are unfortunately or fortunately just a bunch of chemicals in your brain telling you what to do.
Yeah.
And actually, if you can change those chemicals and hormones around, you make different choices and different changes to what you do.
Yeah.
But it's like one of my patients said to me a few weeks ago, a lot of times people are stigmatized for their weight and they're told that, you're only like this because you don't have the willpower to stop yourself. And actually, one of my patients said, you know what, Professor Joseph, I don't wake up every morning, look in the mirror and say to myself, I want to be BMI 35 plus. I wake up and say, I don't want to be like this.
Yeah.
But I've tried and I just cannot make myself control the portion sizes that I need to function and feel like I can function without feeling headachy, sluggish, etc. And actually, once they've gone on treatment, it's like revelation. It's like the whole world changes. We're talking about really life-changing weight loss, where people have felt confident enough to go out and get a new job. People have, gotten pregnant because they've lost enough weight to get their fertility back. Those are the kind of, it's not about the numbers. It's not about how many kilos you lose. It's not about how many pounds you lose. It's about what that means to you day to day that you've never been able to do before. And that's the key for a lot of people.
Interesting. And one thing in terms of long-term, well, I say relatively long-term use is most of the time, I don't know whether this is true, is when you give an exogenous kind of hormone, the natural, production almost decreases. It's the same sort of thing. So if someone was on having a GLP-1 agonist and a GIP agonist, does the natural, production of that decrease? Therefore, the second part of that question is, if they do come off it, are they stuck even in a worse place than where they were before they started the medication?
Yeah. So the trials, right? So you've got to take clinical trials and real life separately, okay? So if you look at clinical trials where people were motivated and they got on the trial and they used medication, they achieved weight loss, we know that there are some trials where they stopped and people were allowed to carry on living with a little bit of diet, lifestyle advice intermittently, or no follow-up at all. And you do find that there is a lot of weight regain. Okay, so it does happen.
Yeah.
So the initial studies in terms of, a time-bound period of treatment suggests that if you stop suddenly, you will regain the weight. So in clinical practice, however, over the years, what I've done and developed with the team is that we realized that you never go cold turkey. If you stop suddenly, you will get rebound hunger, and you see that all the time. So what we tend to do is we get you to your target weight at whatever dose that might be, and then we taper. And then we taper and see if your body has changed. And I have got patients, so you get two kinds of patients. You get ones that are usually a bit younger, who are able to be more active, have made changes, and are proactive in their health. And they will eventually come off it and manage to keep their weight off for a long period of time. Some of them these things have only been going for like 7 or 10 years, right? So we don't know. It's hard to say.
Yeah.
But for the majority of my patients who have reached the target, who are in that category, they tend to be able to stay off. Then you've got the slightly older population. So I've got patients who are in their 60s or 70s, who've got osteoarthritis, waiting for a hip to be done, etc. I can't expect them to go out and exercise to the extent that you need to maintain that. So they come in prepared, knowing that this could be for life. These medications are designed for lifelong use. They're for chronic weight management, right? So once they get to their target weight, what we do is we reduce the dose down, and we allow them to maintain on the lowest dose that's needed to keep their weight where they need it to be. And that's what we do. Now, in the trials, it was slightly different. In the trials, when you reached a target BMI, so if you reach a BMI of 22, what you were allowed to do in some trials was you stay on the higher dose, but actually you're allowed to eat a little bit more so that you don't go beyond a certain BMI. So you can manage it both ways to some extent. So the answer to the question about rebound is you can't tell until you get there. And the best way to deal with it is not to go cold turkey and stop suddenly, but to taper and gradually wean yourself off and see how you go. And only time's going to give you the answer.
And the lowest dose, you maintain that.
Maintain on that.
One thing is about, it's got this Ozempic face. Okay, you keep saying Ozempic because it is about like Ozempic face and Ozempic butt is called. And is that a thing? Is that like, it's because if you're losing fat, or is it you're losing muscle and your skin gets loose, or what?
Yeah, it is a thing. Yeah, it is definitely a thing. So what happens is that when you lose weight, you're losing obviously fat. Now whilst you lose fat predominantly from visceral fat, which is bad fat, which is inside your abdomen, you lose fat from everywhere. That's just the way weight loss happens, right? And whether that be with medication or through diet, you will lose it from everywhere. The thing about treatment with these medications, Ozempic, Wegovy, and Mounjaro, is that because the weight loss is so effective and sometimes possibly a little too rapid, you tend to lose weight from not just the center, but you lose it from places where you don't necessarily want to. So what you're seeing in terms of Ozempic face, as the name says, is actually fat loss from the fat pads in the cheeks and also fat from the gluteal region. So, a lot of people that we try and do, we encourage them to have a slower pace of loss. We warn them to look out for that, have a good skincare routine. I know that there are some patients who will go and get a bit of, sort of filler done and stuff like that just because they want to. And again, I say to people this, right? People will see weight loss sometimes as an aesthetic intervention. For me, I say to my patients, look, I want you to do this because I want you not to develop type 2 diabetes. I want your blood pressure to come down. I want you to not have heart attacks and strokes. Now, if along the way you feel like you're looking better and feeling better as a result of it, well, that's a bonus. And who am I to stop you from enjoying that feeling of upliftment and sort of, feeling great about myself because I look great too. One of the biggest complaints I get sometimes is from my female patients who come and see me, is that their husbands complain that they have to spend more money on new wardrobes sometimes, right? And that's not a bad complaint to have sometimes, you know what I mean? Yeah. But yeah, so that's Ozempic face and Ozempic butt. And there's a whole industry out there that deals with that now as well. But for me, it's all about the weight loss being a life-prolonging, cardiovascular, public health, prevention, intervention. That's what it's about. And you deal with the other stuff to make yourself feel better about yourself with your aesthetic interventions as you need to.
I mean, it's interesting because that's it's a concern people have. But Now there is a very small, but maybe slightly large cohort of people where they don't necessarily want to go down the route of injectables. They can't lose weight. So they, a lot of them are, and they're bombarded with advertisements of hacks that you can take this supplement or take that supplement, take this herb. Are there any herbs that you've come across that either increase your metabolism, help you lose weight, that you think have any kind of effect at all, as opposed to a lot of the junk which is out there?
Yeah, so I have to be honest though, right? There are no clinical trials when it comes down to stuff that's over the counter, right? I tell you, probably the most popular thing that people, especially during COVID, when there were issues and there were shortages of Ozempic and all that kind of stuff was happening, berberine was the thing people talked about.
I've seen that a lot. Yeah.
So berberine is meant to be nature's Ozempic, right? Some people will say that it does help them with appetite control. And to some extent, I say to people, look, committing to medical therapy at the moment, because it's not available on the NHS, is very much a financial commitment for a lot of people. Now, if you can find a supplement that works for you, that is less expensive and is natural and comes with no harm, by all means, try it. I want people to go through the process. It's a process. If you're coming to me and my team to lose weight using medical therapy, you've usually tried everything there is going, right? Yeah. Because it's a big commitment. And you've got to respect that. And so I will always say to people, look, by all means, try stuff. Go for it, but the only person who can determine whether it actually works for you is you. And the thing I say to them is, I want you to set yourself a time frame, because I see a lot of people who are taken in by a lot of the advertising, take this supplement, that supplement, feel better, live longer, all that kind of stuff. But actually, does it really do anything more than a really healthy diet and lifestyle? I don't know. You might feel it psychologically better. But actually, physically, do you rate yourself from a score from day 1 to day 3? We don't make objective decisions about these things, unfortunately. But I would say to you that I don't really comment on stuff like that, because I've never really seen the evidence other than the anecdotal stuff that 1 or 2 people will tell you about.
Yeah, and one thing you mentioned was about, it getting done in the clinic, because this happens with various medications, but in particular, you mentioned the shortage there was of the Ozempic. And that may have made some people kind of go underground, but not via licensed clinics or doctors. That's a dangerous thing to do, right?
It is so dangerous, right? So, I've personally had to deal with people who've come to A&E, given stuff that was in a powder and a syringe and needle that, with a diluent, like a liquid that they had to pour into the powder and inject it. So the one thing I will say to people is, officially, the real stuff only comes in pens. It does not come in powders and stuff in the UK, right? There are certain countries where you have vials of medication, because it was manufactured in vials too, but it comes in pre-mixed vials, not as a powder and stuff. So you get also people who say they are compounded, so they've been made in a pharmacy somewhere, and it's the same thing, but you don't know, it's not been tried and tested in clinical trials. You don't know the dose conversions. You don't know how much you should start with, follow through with. Whereas all the stuff that we use, the Mounjaro, the Wegovy, has gone through clinical trial testing over years in thousands of people before we get to the point where we can use it on people, right? So the things you worry about are people who label insulin pens with a sticker. I've seen that. And I have to report that. So you take insulin, all that happens is your blood sugars plummet, you pass out, and you're in trouble, right? People who inject stuff that we don't know what the hell's in it. And that then causes you to vomit. I've seen people end up in A&E vomiting for like days and days on end, dehydrated, and their kidneys are dried out. So what we call acute kidney injury. So there's a lot of stuff out there that you just want to steer clear of. And unfortunately, there are beauty outlets and hairdressing salons and stuff where people will tout this stuff. And actually, there's no recourse to this, right? So if something goes wrong, if you come to us, if something goes wrong, we're held responsible, and we'll put our hands up, we'll support you, we'll look after you. But actually, if you go to someone who's unauthorized to do this stuff, what recourse do you have? And we write to your GP, we keep everybody informed. That's just part and parcel of good clinical care. And also, you've got someone at the end of the phone 7 days a week, if you need it, to be able to answer, if you get a problem coming through. And it's just about doing it right and doing it under proper clinical supervision, and that's the way it should be done. It's a medication.
It's key. I've seen complications as well. People give it not specifically for weight loss, but other things like benzodiazepines and things they've bought, and you don't know what's in there, right? So one thing that I think is linked in quite a lot with weight and weight gain is the thyroid system, right? And I think it's been quite a contentious topic, especially in the UK, around sort of T3 prescribing. So if you could go through exactly what T3 is and why it's important and its role in the whole thyroid system.
Okay. So the thyroid is an interesting one. So I get a lot of patients with hypothyroidism who, or an underactive thyroid. Let's not use technical terminology.
Yeah.
So an underactive thyroid, right? And the internet's a great thing because actually people do a lot of research. They look at their symptoms. They've identified there's a problem. And now you can access like blood tests online and stuff. So it's a great time for people to take control of their health. And you'll get some practitioners who will just say, oh, I hate Dr. Google and I don't want you going there. But actually, I prefer my patients coming to me well-informed because actually I can have a really good discussion with them.
Yeah.
So the thyroid, I mean, let's go back to basics. What's the thyroid? The thyroid is a little gland that sits in your neck. It's shaped like a butterfly. It makes the thyroid hormone. The thyroid hormone is your hormone of metabolism. It's the hormone that maintains the rate of your metabolism, and that applies to your brain, your muscles, your inner organs, kidneys, livers, etc. Everything works at a certain rate. And that's because your thyroid hormone keeps it that way. It regulates your temperature. Now, thyroid hormone in the broadest term contains two main hormones that we talk about. That's T4 or thyroxine and T3 or triiodothyronine. Okay. In simple terms, T4 or thyroxine could be considered the precursor. So it's the inactive version of the hormone. It floats around in the blood, but when it gets to where it's supposed to do the job, so to the brain or to the kidneys or to the liver or to the muscle, or to specifically also brown adipose, there's a special type of fat cells called brown adipose tissue, which maintain your temperature regulation, right? So when you get there, the T4 gets converted to T3, and T3 is the version of the hormone that does the actual job, okay? But the thyroid puts out about 80% of what it puts out is T4 and 20% is T3. Now, when you get to the cellular level, it's the T3 that does the job. So what happens in some people, if you have an underactive thyroid, you're not making T4 or T3, okay? And the commonest thing that we tend to find is autoimmune hypothyroidism. Some people will call it Hashimoto's. But essentially that means you have a genetic tendency to make antibodies that should be fighting things like viruses and stuff. But they turn on you because they just want to hang around and there's no virus to do anything to. So I'm going to turn on you and just have a bit of a party and cause a bit of havoc and shut down your thyroid. So when you shut it down, we traditionally would give you levothyroxine, which is T4 or thyroxine. Now, for 99.9% of the population, levothyroxine probably does what it needs to, and they live their lives, and they just get on with it, right? Then you've got a small percentage of people who, no matter how much levothyroxine you give them, just don't feel like their hypothyroid or underactive thyroid symptoms have disappeared. They're still tired. Their brain's not working right. They're cold all the time. Everything's just a bit sluggish. So in these people, we will find that T3 supplementation can sometimes be beneficial. Now, there's one scenario where you have, so the way that the T4 is converted to T3 at a cellular level is with an enzyme called the deiodinase. So it basically gets rid of an iodine molecule. From 4, you go to 3. You get rid of one iodine molecule, right? Yep. Now, some people have a deficiency in the deiodinase 2 enzyme. So it's a genetic issue. And those people don't convert T4 to T3. So in them, theoretically, if you give them T3, they start to see the benefit. So often I get patients who will come to me and say, well, actually, I can't get this on the NHS. And why don't we get it on the NHS? Because the NHS, rightly so, goes on evidence-based. Okay? And when you look at evidence-based, you and I know that everybody looks at randomized controlled trials. You've got to have good quality evidence. Now, the problem with that is T3, patients needing T3 and patients, who benefit from T3 are such a small number. And there's no reason, impetus for people to do a large-scale randomized controlled trial. There have been some trials done in the past which showed that actually didn't make any difference. But the problem with those trials was that it was tried in a random population, whether you were feeling the benefits of T4, i.e. levothyroxine, or not. Whereas if you narrowed it down to people who complained of, I don't feel great, despite my thyroid levels being, as high as I can get them on levothyroxine, then you would probably have seen that benefit. And so because it's an individual thing, smaller numbers, and that evidence base just isn't there, the NHS, as I've said, rightly so, based on its protocols, principles of evidence-based medicine, says, well, actually, we don't want to use T3 because it's not been proven in those large-scale trials. There is also a little bit of cost involved. So T3 is expensive, a lot more expensive than T4 or levothyroxine. And I'm sure that also has a role to play in it. But I think it's the evidence-based argument that we use, in terms of how the NHS has to function and the guidelines that it's based on. But for the individual patient who comes to me, very happy to give them a trial. And that's what I say to people. I say, look, I can't guarantee you that this is going to make you feel better, but I'm happy to try it. But before you try it, I want to make sure everything else has been checked out. So make sure that your vitamins, your minerals, all that's been taken care of. Make sure that, we've thought about, have you got sleep apnea syndrome? Could that be contributing to your fatigue? Let's make sure you're not perimenopausal or menopausal, and let's deal with your HRT issues first. And then if after all of that's been done, and I've thought about every other condition I can think of that's making you feel the way you are, then by all means, invest in yourself. And if you want to try some T3 in the form of either liothyronine or in the form of natural desiccated thyroid, which is another option that a lot of people like to use, they just feel better on it, then I will give them a trial. And often once they do it, everything just switches on and they're like, I'm never giving this up again. And they will carry on looking after themselves and fund it for themselves. So I think there is a role for it. It is very individual, and it just needs to be done with the support and supervision of someone who knows what they're doing.
Interesting. And I love your thoughts on this, because since lockdown, COVID, pandemic, people have been coming in, and I have seen even just in primary care, the number of questions around thyroid query autoimmune related. Now, not just thyroid autoimmune conditions, but just autoimmune conditions in general. So lots of people are coming in with these weird kind of syndromes of symptoms that don't fit anything. And a lot of has been made out, is it an autoimmune thing? Is it down because people are locked down? Does that trigger things? I know it's maybe too hard to, but was it the vaccines? Was it having COVID itself? What was your kind of opinion of the whole thing in the pandemic and how it's changed the outlook of health, in particular autoimmune conditions?
Yeah, so I think that there's been a huge impact. So I think we were already on a trajectory where autoimmune conditions were coming to the fore anyway, right? And that's happened in around the world. So we know that as people die less, if you look at the developing world, most people die from infective conditions, right? Because even to this day, in the developing world, infections are the major killer.
Yep.
But in the Western world, that's not the case, because we have great healthcare, we have antibiotics, we keep people alive, and they don't succumb to infection unless there's a overwhelming sepsis or something that we aren't able to handle. So what that does, it's called the hygiene hypothesis. So when you do the hygiene hypothesis, you've dealt with all the infections. So what have you got left? Well, you've got autoimmunity left. And that's why we see more and more autoimmune conditions. But what did COVID do, right? So two things I think COVID did. So we know that COVID had a definite impact on autoimmune triggers. So a lot of people who might have had latent genes that predispose to autoimmune dysfunction showing up. So for example, thyroid, let's take thyroid as a good example. So the theory is that, so people often ask me, why did my thyroid become overactive or underactive, right? What was the trigger? And this is, I'm talking about in autoimmune under or overactive. So hypothyroidism, which is Hashimoto's, or Graves' thyrotoxicosis, right? So in these two scenarios, the way I often say it to them is, look, we know that there are certain so often a virus starts the process. Your body starts fighting off the virus then disappears, and your body's like, well, okay, I've got a lot of antibodies around. What do I do now? And it turns on itself. COVID was a time when we saw an increase in that kind of trigger. And I think that's why we saw a bit more of that. The other bit around the vague symptoms, as you talk about them, and this constellation of symptoms, that we know that COVID definitely had an impact on the autonomic nervous system. So we see a lot of people with inappropriate tachycardia, POTS symptoms, so postural orthostatic tachycardia symptoms, right? We see people with fatigue, obviously. We know that post-COVID, long COVID, there's been a lot of fatigue-related issues. And we see people who have, aches and pains that they never had before. And so we have got a constellation of conditions where somehow COVID or even the vaccine potentially, although, the jury's out on that, had an effect on people's autoimmune system, their autonomic nervous system, and created this set of conditions or symptoms that we now have to unpick. And I often end up saying to people that, we can label it whatever you want to label it. It could be long COVID, it could be POTS, it could be any of those. but actually what's the practical way to get you feeling a bit better. And there are things we will try out to try and help. So, I see a lot of young people with those kind of symptoms, and we manage them with, stuff like fludrocortisone to try and keep their blood pressure and keep their heart rate under control. We'll try them on ivabradine, beta blockers. Yeah. There's all kinds of stuff that we do, but it's all about symptom management. So you're right, COVID kind of created this whole new set of things that we now have to contend with. The autoimmune thing definitely came to a fore, but also I think it's about people's awareness. That people are like, I don't feel right, I need to get checked out. And they will proactively go and do that. Whereas back in the day, I think we'd sit back and say, I'll wait and see how it goes. And, things wasn't as accessible. So I think it's a whole combination of things.
Now, linking onto that, one thing is around just cortisol. People are saying, I think people see cortisol as bad. It makes you fat. It makes you have a puffy face. It makes you tired all the time. There's all these like low your cortisol diets, things. But, I think it's important to just we talk a bit about cortisol itself and its importance and why it may potentially cause problems. Because I think a lot of people have questions. A lot of people are asking me online to do videos around that specific thing, just cortisol, and is it good or bad? Which is obviously hard, which is hard to say, but if you could try.
Yeah, so cortisol, right? So the first thing to say is when you talk about cortisol, you have to talk about it as a high cortisol has to be divided into two things. Either it's a physiologically high cortisol or it's a pathologically high cortisol. What does that mean? So physiologically high cortisol means that your body, for whatever reasons, is making more cortisol to look after you. So the commonest reason for that tends to be stress, lack of sleep, just on the go all the time. It's that flight or fight response. If you're constantly stressed, constantly on the go, pushing your body to the limit, pushing your mind to the limit, how does your body cope? It copes by making more adrenaline to help you with that. But at the same time, from the adrenal gland, it's also making higher amounts of cortisol. So the moment that you are in that state of flight and fight all the time, you have a higher cortisol level. Now that is not the cortisol doing bad things to you. Yes, it might do because it's high all the time and aggravates the situation. But actually, what's the solution to that? It's not a medical solution. The solution to that is dealing with the underlying issue, which is you're doing something that isn't conducive to your health. And actually, if you can ease off on that, you'll bring your cortisol levels back under control.
Just before we go to the pathological causes, what are the effects of long-term, stress is a very common one. What damage can that constantly high level cortisol do?
So in terms of damage, what it's doing is, so cortisol as a hormone, right, is insulinogenic. So basically it is increasing insulin resistance. And as a result, you have a tendency to weight gain. It also, as a result of the high cortisol, is pushing your blood pressure up. So essentially what it's doing is making you, with that high cortisol, gain weight, have a higher blood pressure, and generally having an impact on your health that you will see if you start to put on weight, because it also drives hunger. So the higher your steroid levels, the more hungry you feel. So essentially what you're doing is by sleep depriving yourself, if you're not getting a decent amount of sleep and having a good sleep, sort of routine, if you're stressed all the time, high-powered job or whatever you do, and you're just like constantly on the go, that cortisol level is driving you to feel hungry, increase your insulin resistance, gain weight, especially around your abdomen, and just make you feel rubbish. So that's the problem. But there's not a medical solution to that. The problem there is it's what are you doing to yourself? Take a step back and deal with that. And that's a completely different ballgame from my world, where I'm looking at pathological high cortisol, where you might have a growth in your pituitary gland or your adrenal gland that's putting out the hormones that, eventually, so if you have an adrenal adenoma, as we call it, that will put out excess cortisol, that then causes Cushing's syndrome. You can get a pituitary growth. So your pituitary gland controls cortisol production in your adrenals, and that is called Cushing's disease. So those are two different things altogether. There are tests that I would do to see if I can switch off your cortisol production. It's something called the dexamethasone suppression test. We do a urine collection to look at excess amounts. And there's a medical intervention. And that's a whole different ballgame, right?
Yeah, I think it's hard. I think... Yeah, we make that distinction because you'd think hopefully the pathological will get, you'd get picked up on the NHS. And I think where people don't realise is the lifestyle stuff you're talking about and how key it is, sleep, diet. Another one is inflammation, right? People throw this word out, inflammation. But it's so hard to, not even measure inflammation, but explain, because inflammation happens naturally, right? We all get inflamed even after we have a meal, for example. That's a normal process. But chronic, not pathological inflammation, but is there such thing as a physiological inflammation that can cause you to feel bad?
Yeah, absolutely. So it's an interesting. So I think going back to, so a good example of where I have to have this conversation all the time is patients with PCOS, right? So polycystic ovary syndrome has chronically been shown to be, not chronically, it's been shown to be a chronic inflammatory state. If you measure CRP, so C-reactive protein, which is a blood test that we do in people to look for inflammation, you'll always find that women with PCOS, age matched against women without PCOS and the features of PCOS, have a slightly higher level of this C-reactive protein all the time. And it goes back to that inflammation being secondary usually to triggers. And those triggers, in most cases, tend to be dietary, right? And if you can deal with those dietary triggers, you find that inflammation comes down. And that inflammation can be manifest in terms of, fatigue, aches and pains that you can't explain, headaches, joint pains, sometimes rashes. There's all of that to contend with. Again, post-COVID, something that we've seen quite a lot of is that kind of constellation of GI intolerance to various foods. You tend to find kind of rashes that kind of come from out of nowhere and stuff like that we also tend to see. And actually, the whole gut health thing has come through showing that actually, and I don't really know what it is. I mean, I see every day in my practice more and more people complaining of gluten intolerance. Now, I don't know whether that's because we're changing as a race. It's not full-blown celiac, right? So you have a condition called non-celiac gluten sensitivity, so NCGS. And NCGS is you don't have full-blown celiac, but you react to gluten, and you know it because when you eat bread or pizza or pasta, you end up bloating and windy and all that kind of stuff, and you feel uncomfortable. You get rid, and you feel much, much better. And actually, what we're seeing is that if you can focus on those triggers, you find that the inflammation, your symptoms, all of that just starts to calm down quite a lot, and you have a much better quality of life and much improved symptoms.
It'd be interesting if someone did like a study on themselves and checking the CRP after having something healthy and something unhealthy. As a one-off, it probably won't do much, but if you're doing that every kind of day, that chronic inflammation will be. What's your thoughts on these glucose monitors? Not for type 1 diabetes, what they were designed to, but in terms of people kind of marketing them as, lifestyle management of.
So I think there's a role for them. So the main thing here is what you've got to remember is that when you use it in the diabetes world, your blood sugars show a much bigger fluctuation, right?
Yeah.
Okay, so you can actually see the difference. When you're doing it in the non-diabetes scenario, so if you're a healthy person who's just wanting to be healthier, then what you're looking at is very small deviations in the glucose fluctuation on these monitors. You can still see it. If you eat something that is of a high GI, for example. So I'm going to introduce the word GI now. So glycemic index is something that people should be aware of. So what is glycemic index? So glycemic index is the rate at which a food is broken down once you've consumed it, so that either you get a high glycemic index, which means that the food gets broken down so quickly that you have a big sugar spike in your blood, or you have a low glycemic index where the food's broken down slowly, so you get a very gradual increase in the glucose, right, in your bloodstream. So if you can see the bloods that are high glycemic index, which these monitors will pick up on, and you can eliminate them, you are likely to have less weight gain. The reason for that is the higher the spike in glucose in your blood, the more that top bit that you overshoot is stored up, because you don't need that for energy burn. What you need is the lower level to keep your calories burnt for your muscles, your brain, etc. to work. And essentially that extra spike that you get from high glycemic index foods is what causes you to gain weight. So if you can use the technology to modify your behavior, and that's what this is. It's about behavior modification. It's about telling yourself that actually what I'm doing ain't right for me. I need to do something different. And if you can change your diet using that technology, well, that's a great way to use it.
Yeah, it's interesting. I sometimes thought maybe if there was like a CRP monitor or something, that'd be even better, because that gives the direct response of saying that this food gives me inflammation, which is a direct response, obviously, of all the bad stuff we just spoke about. But it's interesting because I think that's been a massive thing you see everywhere, And I guess when people talk about high GI foods, it's different for everyone. And that it was kind of what you're saying, and it doesn't, because sometimes even porridge for some people can be a bad thing,
Absolutely.
right? But generally it's thought to be a good thing, which isn't always the case. Okay, so I know I could pick your brains all day, but I think one thing I think that I really want to question about is sort of steroids and anabolic steroids. I think the use, I mean, there's a whole legality thing around it. In the UK, you can, use it, but you can't supply it, that kind of thing. And in America, it's different. But I think the use of people using it on social media has gone up. I think that's good in a way because it's saying, look, it's giving people, this is not what you can get naturally, right? I'm enhanced. But on the flip side, it's almost saying, look, it's fine to use them because I'm using them, it makes me look like this, So I think you have to balance that. But I want to know, what do you see in your clinic in terms of anabolic steroids? You must see it, the bad side as well as the good side, if there is any.
Yeah, so I don't think there's a good side to anabolic steroid use if you don't need it, right? So, I mean, you definitely have a population of people, of men, who use anabolic steroids for muscle building, okay? Now, some of that used to be about pro athletes or athletes who, from an athletic point of view, wanted to enhance their performance. But at some point, I think the tide kind of turned and it became a bit aesthetic again. And I think that's where the problem is. You can understand, I don't know if you can understand using it in athletes, but it has been a done thing. And obviously there's a whole stigma around that as well. But, in my clinical practice, the challenge for me is when men have used anabolic steroids to enhance their performance or muscle build, what they don't realize is what it's doing to them long term. Nobody talks to them about this stuff, right? So I get men who come to me often saying, oh yeah, back in the day, I used to inject Sustanon or, Nandrolone or whatever it was they were using to try and build. And then after that, they got past that phase in their lives. Then they got into a relationship. And often it gets to the point where they're thinking about having a baby and suddenly things aren't working so well. And that's one scenario. The second scenario you tend to get is where men have been on treatment, and then suddenly stop treatment and they crash because their body's gotten so used to being roided up or, running at a high where their, testosterone or whatever anabolic steroid they've been using has just kept them running at a higher level. And then suddenly they crash and they don't like the way that feels. And that's natural in a way because you've come down from a high. The challenge you have there is what's the right thing to do? Because actually, once you stop using, you can regain your own function. It could take months. It could take a year. It can take years. But it's what are you trying to achieve in that time? It's one thing that, we have to balance up in terms of, what am I trying to achieve for you? So it's an open conversation to say, look, if this is just about how you're feeling, I think one of the things you got to decide is how bad is it? Is it bad enough for you that I need to treat you? But remember that once I start you on treatment, you're on it for life potentially. Is it about you wanting to have a family? And do we need to think about, are you making enough sperm? Has that been switched off? What can I do about it? And there, then the conversation goes into, so a lot of men do cycles. So you do post-cycle therapy sometimes. It's in vogue to use testosterone in injectable form and simultaneously use beta-HCG. So HCG obviously is a form of, sort of male hormone or a sex hormone in a sense, which encourages sperm production and testosterone production at the level of the testicle. And some men will do that and therefore try and preserve testicular volume and size and function. It works for some. In men who haven't done that, then sometimes what I have to do is think about treating them with HCG. Sometimes I'll use a medication called clomiphene, which sometimes is useful in that scenario. But often it's a question of saying to them, look, you just got to give yourself time and it will pass and you may get your functionality back. Now, that's a different scenario from men who have symptoms of erectile dysfunction, low libido, fatigue, all the stuff that we call the male menopause. And there it's about if you're getting symptoms of you've never had anything before, no anabolic steroid use, no testosterone previously, then you need checking out. You need the biochemistry to confirm. You then need additional biochemistry to look at, is the problem up here in the pituitary, which controls the testicles, or is it a testicular problem where you're trying to look for primary gonadal failure, right? So there's a whole series of things that have to happen if you are presenting genuinely with those issues. As time's gone by, obviously, as the obesity epidemics increased, we're seeing more and more hypogonadism. And that's a secondary or hypopituitary or hypogonadal hypogonadism because the metabolic syndrome with type 2 diabetes, high blood pressure, high cholesterol, sleep apnea is associated with a low testosterone production because the messages from up here don't get to the testicles to make the right amount of testosterone. So again, there's a lot to consider there in terms of diagnosis. What is the appropriate treatment? What are you trying to achieve? And there's a whole discussion to be had around preserving fertility, or have you finished your family? Do you want to have gels or do you want to have injections? Do you want to have 3 monthly injections in the form of Nebido, which you can get from your GP? A lot of men now opt for privately funded stuff. So traditionally, we've always used intramuscular testosterone. There's evidence now to use subcutaneous testosterone, which you can use in the form of enanthate and cypionate. Some of which is available on prescriptions, some of it's specials that you have to, use off-label. So there's a whole discussion to be had around it. But the problem is that, as you said, it's good for people to be aware, but when you're using it for bodybuilding or aesthetic purposes, that's when you're not taking into consideration the long-term effect it has on you. And there is a whole monitoring strategy around prostate management, around checking your hematocrit, all of that needs to be.
I mean, it's interesting because I think we live in it's more of a cultural thing, I think, with social media. So there is a cohort of people that no matter what you say will go and do it. So just devil's advocate here, I'm saying, is there an argument to say, look, doctors, for those kind of people, wouldn't it be best to get anabolic steroids prescribed by a doctor rather than going to someone on the ground? Now, obviously, isn't that, we can't do that, but for some, that might be a valid argument, right? That's the safest way to get it done, is by almost a bit like the weight loss. Go to a doctor, get it started, monitor for side effects, that kind of stuff.
Yeah. You're right. And, I do have 1 or 2 patients who do that. And I've tried to discourage them from doing it. Unfortunately, it doesn't, falls on deaf ears. But they will come back and say, look, I'm doing this, I know, and all I want is for you to tell me that I'm safe, and I will do some blood tests. I will make sure that their hematocrit is checked to make sure. So one of the key things is when you're overdosed or too high a dose of anabolic steroids or testosterone, your bone marrow starts to make too many red blood cells, something called polycythemia. And polycythemia runs the risk of strokes. So essentially your blood is thicker and therefore sludgy. And therefore if you don't take precautions to bring that back under control, ease off on the dose, etc., you run that risk of stroke. So we monitor their hematocrit every 6 or 12 months. If you're over the age of 40, you need to be checking your prostate, PSA on a regular basis. So there's those bits that you can do to support someone. But I think it's also about the open conversation to say, look, there are risks to this, especially overdoing it. And, you need to think about it. And every opportunity I get when people come to me, I say, the best I can do is say, look, it ain't great. You really need to stop. You really need to think about stopping. But if they ignore that advice, I guess the second best thing you can do in these scenarios is take a more sympathetic view and say, look, at least let me keep you safe. And I agree with you.
Check your levels and bloods and stuff.
And that's all you can do.
Yeah. What about steroid rage or roid rage? Do you see many patients with that? Because I guess theoretically it makes sense with such a high testosterone. That's going to manifest in many ways, and one of those is, cognition-wise. Yeah,
absolutely. So, I mean, you don't tend to see a lot of that in outpatient clinical medicine, and I think even when people go and get this stuff from a gym, they're often supported by very sophisticated sort of systems in place where the people, sort of supporting them with it do know a little bit about what they're doing in the sports arena, the bodybuilding arena. So they don't often get to that stage. The thing that, sometimes you get is they go on a high dose, they start to get ankle edema, they get really bad acne, they start to lose hair, and they're like, oh, well, I feel great, but I'm losing hair. I'm like, well, that's part of the deal, is that, you're getting androgenic alopecia because you got more testosterone, you're losing hair, and you're getting male pattern balding. And there's all of that to contend with, and it's trying to make sure people are aware of the consequences of having these agents in their system and making sure that those things are looked after on a regular basis.
Now, you mentioned earlier about the male menopause. want to touch briefly on, is that inevitable? And also, I've seen a lot where patients will get their testosterone checked. A lot of the time, it's important to say when, timing, if it's all done in the morning, done correctly. Because there's a lot of things people can do, like, that can artificially lower it or raise it, right? It's quite it's not a thing that's in the market.
Yeah.
And some of the patient might be just on, like, within the normal range, but on the very low end. And in this situation, like, what do we do? Do we treat them as a person, right? And say, look, okay, yeah, I think you probably do need a bit because you're feeling horrible. Or do you go strictly, you're in the normal range, you can't have it,
Yeah. So the rules are the rules for a reason, right? Because if you start to bend the rules too much, then it grays it out way too much. And if you follow most guidelines, NICE, or there's something called the BSSM, the British Society of Sexual Medicine guidelines that most people will use, and most areas in the UK, most area prescribing committees will have guidelines of their own. But the general consensus is that if you've got a testosterone that is less than 12 nanomoles per liter, but you must have symptoms, and a lot of them will define those symptoms as erectile dysfunction, low libido, amongst other things. The vague symptoms on their own, fatigue and stuff, that's not enough. You got to have sexual sort of impairment symptoms, right? And essentially, if you've got those and you've got a level that is 12 or below, then you have a justification for a trial of treatment to see if you feel better. Now, if you have pre-diabetes, okay, so if you have impaired glucose regulation, so HbA1c that is between 42 and 47, that actually goes up to 13, the cutoff, right? Okay. So because it goes with the whole metabolic syndrome thing. And actually, there's studies out there that show that giving men with a low testosterone, giving men testosterone who have a low testosterone with pre-diabetes and diabetes actually almost has a better cardiovascular outcome than treating their diabetes or blood pressure sometimes. Wow. Yeah. So there's some data out there as well. So I think there's definitely a rationale for doing it. I think if you flex it too much, it becomes a very gray area and you start to, you're in the realms of risk. It's not that it's not done off label, but you can't treat someone's low mood based on a testosterone that's borderline sometimes.
Yeah. It's interesting because I think that was my question, because I'm seeing lots of people doing it online. Because you get it online now, it's essentially a simple questionnaire and you get prescribed a testosterone gel. And people almost deem it to be safe. But what are some of the risks you can have of taking testosterone if you don't need it as a male?
Yeah, so in terms of the long-term risks, it depends on your age and depends on what else you're dealing with, right? But it's that main things are the polycythemia risk, and the second is the prostate cancer risk. It doesn't cause prostate cancer, but as men, as you get older, you have a risk of developing prostate cancer. And what you need is a system in place to check, monitor, and do that safely. So that's important. From a cardiovascular point of view, there isn't a huge risk there as such. And I think, it's a difficult one because actually you don't see a lot of risk in doing this. But some men, if you go overboard, actually, if your levels are low, you get erectile dysfunction and low libido. But if your levels are too high, you get the same as well, right? So it's about finding the happy medium. But again, it is a question of why are you doing this? Does it really keep your life for longer? Does it really do much for you? Or is it just the fact that you got to accept that as time goes by, there's something else that you might need to deal with? Or this is just you to some extent. And you got to manage your health without extraneous things that you need to put in yourself.
And what about in women? Because a lot of time, I've seen it used fantastically in perimenopause or menopausal women, where they've tried various different HRT regimes, just the estrogen and progesterone, and then they start on testosterone, and everything just changes, right? And I think I do feel for women sometimes. I definitely feel for women because testosterone in women is so misunderstood, and sometimes they're denied it completely, or the conversation not even had.
Yeah.
But it's very important, right? In women,
absolutely. So you cannot underestimate the effect of postmenopausal low libido, right? So in terms of a lot of the patients I look after with menopause, you get their estrogen, progesterone right, you get their levels as good as you can, and you get them so far. But the key thing that a lot of clinicians will not ask a woman, and a lot of women, because of embarrassment, will not be forthcoming about, is libido. And so I make it a point to make sure I ask them, look, you feel great, you're flushing and you're sweating, it's all better, you're sleeping better at night. I'm glad that it's all working out. How's things with libido? And then it's just like, oh my God, it's non-existent. And we're constantly fighting. My husband just, that kind of stuff. And I say to them, well, I think you need to try some testosterone. And there is such a great amount of response that you see it is again one of those things that almost switches. A switch goes on, and life is back again.
It's amazing. I've seen it. Yeah. I've seen it. It literally is like that. It's quite incredible. And what are your thoughts on sort of Shilajit and Tonga Ali? These are rife. In particular, they're used for testosterone, and ashwagandha is another one.
Yeah.
And there are some very low quality studies out there saying it does help. But there's no, as with all these things, there's no
hard and fast, and again, I say to a lot of my patients, look, if I've gotten you 90% of the way there and there's 10% that I can't get you, and often that's the case, right? With the best will in the world, a lot of the treatments we give are never going to replicate everything that was normal beforehand, right? They'll get you so far. And I say to them that there is a reason why Ayurveda and homeopathy and stuff have been around for centuries, is because they knew certain things. I mean, just because we packaged it up in a box and made it in a factory and called it medication doesn't mean that there isn't a whole knowledge base out there of natural things that can potentially give you some benefit. But what I do say to them is, look, try it. Ashwagandha is a good example. I say to them, try it, but make an objective decision as to whether it's working or not. Because when I try patients on HRT or transdermal testosterone,
you can measure it, right?
You can measure the numbers, but it's more than... So I don't measure testosterone values after starting it. It's all about symptom relief. But women will tell you, I feel great before and after. Do you know what I mean? They'll say, I felt miserable, I feel great.
Yeah.
When you try something like ashwagandha or another sort of over-the-counter sort of, Ayurvedic supplement or a supplement of some sort, you don't always get that switch on effect. It's very subtle, if at all. And I ask them, look, if just like I give you something and ask you a question, you need to ask yourself, this is how I feel today. I'm going to do this for 6 weeks or 3 months or whatever and see how I feel. And if it ain't making a difference to you, well, then don't. But if you think it is making a difference to you, carry on. So I'll give you a good example. Magnesium's a great example. So a lot of women at the perimenopause and menopause who can't sleep, who get a lot of sort of irritable legs and stuff like that, you give them magnesium, really works, And again, there's an evidence base behind that. But it's not a prescribed medication. You just get an over-the-counter magnesium supplement. So there are certain things. I mean, even if you take stuff like black cohosh or evening primrose, there's a reason why these things have been around for so long. It's because people have tried them in the past and it's done something for them. And I think it's about try it. If it works for you, great. If it doesn't work for you, you always know you've got a medical option behind it that you can try out too.
That's great. I think... great answer, because I think the worst thing we can just say is doctors, I don't know. Because a lot of time earlier on in my career, I'd be like, okay, I didn't really know much. I'd say, okay, look, stay away from it. But in fact, I love magnesium, as a glycinate for, for restless leg sleep, that kind of stuff. It works, low risk, go for it. So I think, that's a great response. And that's what I say to patients as well. Right. We've covered so much there, and I think what people don't realize is that your weight loss clinic is a thing everyone can access, right?
Yeah, absolutely is. Yeah. So all they have to do is go on www.drfranks, so that's Dr. Frank's, drfranks.co.uk. We look after people from all across the UK. And all you have to do is get online, book a consultation with one of our nurses. All our nurses are sort of diabetes and obesity specialist trained, working either in secondary care or primary care in the NHS actively, and they do sort of part-time hours with me. They're people that I've worked with and sort of brought with me along the years. My ethos in this has always been healthy is the new happy. So at the end of the day, if I can get a population of people healthier, happier, I'm doing public health a service, I'm doing the individual a service, and actually the gratification that you get when people tell you that, my life's changed, there's nothing that can measure that value that you get from, in terms of job satisfaction. So I love my job and I love doing it, and hopefully we'll do it for more people.
No, well, again, thank you so much for coming on. And look, I'm sure there'll be lots of questions around this, but I'd love to have you on again in the future to discuss. I've got like a long list here, which we haven't got time for, but definitely part 2 at some point.
Fantastic. Thank you, Asif, for having me. I appreciate it.